Imagine you're prepping to perform a really delicate, high-stakes repair on an engine.
Okay, I'm picturing it.
Right. But now imagine you have to do it while the engine is actually running,
Mhm.
and the entire vehicle is tilted vertically.
Which sounds completely impossible, honestly.
It does. And to make it worse, if your tools press even a fraction too hard against the outer casing, you could cause, like, permanent, irreversible damage to the whole electrical system.
Yeah, that is a serious high wire act.
Exactly. And that intense balancing act is pretty much exactly what pelvic floor surgeons face every single day.
It really is. And, you know, it challenges a lot of our basic assumptions about medicine. We tend to think of the human body on an operating table as this fixed object.
Like a static blueprint or something.
Right, exactly. But in the reality of an OR, human biology is constantly interacting with the physical forces of the room itself. I mean, gravity and geometry are literally just as critical to a successful outcome as the scalpel in the surgeon's hand.
It's so wild to think about it that way. So today, we're taking a deep dive into the hidden mechanics of the surgical world. We've got a fascinating stack of sources today, from anatomical textbooks to surgical manuals and even some Australian mechanical patents.
A really diverse mix of material.
Yeah, and our mission for this deep dive is to uncover how the highly precise geometry of patient positioning, specifically moving from the standard lithotomy position to a dorsal lithotomy with pelvic elevation, is the ultimate key to unlocking surgical access.
Right. Access to one of the most delicate, complex areas of the human body, which is the anterior vaginal wall.
Okay, let's unpack this, because to understand the upgrade, we have to start with the baseline, right? We're talking about the standard lithotomy position.
Yeah, before a surgeon decides to, radically alter the geometry of an operating table, they always start with the foundation. And this one has an incredibly long history in medicine.
So if you've ever watched a medical trauma, or honestly, if you've had a basic gynecologic exam, you know exactly what this looks like. The patient is lying supine.
Which just means completely flat on their back.
Right, flat on their back. The hips and knees are flexed at precisely 90-degree angles, and the legs are abducted or spread apart to about 30 degrees.
And then the lower legs are supported in stirrups.
Exactly. So where does this come from?
Well, the name itself actually tells a story of ancient medical necessity. So lithos is Greek for stone, and tomy means to cut.
Oh, wow. So literally cutting for stones.
Exactly. Centuries ago, well before we had advanced imaging or, minimally invasive tools, this very specific physical posture was developed for one primary reason, and that was extracting bladder and kidney stones through the perineum.
Ouch, that sounds intense.
It was. An ancient surgeon required the absolute most direct, unimpeded physical access possible to that specific region. And today, it still remains the absolute foundation for childbirth, urologic procedures, and basic pelvic medicine.
Yeah, I'm trying to visualize the limitations of this, and the best way to think about it is like exploring a narrow cave system.
Okay, I like that analogy.
Right, so if you stand at the entrance of the cave with a flashlight, you can see the floor, you can see the immediate walls around you, and you can easily manage anything right at the opening.
Which is your standard exam.
Exactly. But you absolutely cannot see the ceiling of the deepest cavern all the way in the back.
What's fascinating here is that is the crucial limitation. The standard lithotomy provides really excellent access for general surface-level procedures.
But it falls short for the deep stuff.
It falls significantly short when a surgeon is tasked with highly complex pelvic floor reconstructions. Standing at the entrance of the cave, like you said, simply doesn't get you deep enough into the anatomy.
And reaching the ceiling of that deep cavern is what forces surgeons to abandon the standard setup altogether. And in this case, we are talking specifically about a condition called anterior vaginal wall prolapse.
Right, which is frequently referred to in clinical settings as a cystosol. And this condition affects a massive portion of the population, particularly as tissues age or following the physical trauma of childbirth.
Right, it's incredibly common.
It is. But to understand how to fix it, you really have to realize that the anterior vaginal wall isn't just like a barrier or a passive lining. It actually functions as a vital structural support hammock.
It's essentially the floor for the bladder, right?
Exactly. The upper vagina rests on a muscle plate and is stabilized by this dense, intricate web of connective tissue. That's primarily the pubocervical fascia.
Okay, so it's a structural web.
Yeah. And when those supportive tissues fail, like when they become detached or stretched beyond their elastic limit, the base of the bladder basically loses its physical floor.
And once that structural floor is gone, gravity just takes over. The bladder literally drops downward and physically bulges into the vaginal canal.
Which is incredibly uncomfortable for the patient.
I can imagine. And to fix this, surgeons perform what's called an anterior colporrhaphy. They have to make a full-length midline incision along the vaginal wall to reach a highly specific area.
Right, called the vesicovaginal space.
Yeah, the vesicovaginal space.
And that space is fascinating because it's what surgeons call an avascular plane.
Meaning there's no blood vessels.
Essentially, yeah. It's a natural boundary layer of connective tissue between the wall of the vagina and the wall of the bladder that lacks major blood vessels.
Oh, wow. So it's like a safe zone.
Exactly. A skilled surgeon can navigate this natural cleavage plane to really carefully separate the vaginal wall from the bladder without causing massive bleeding. And obviously without puncturing the bladder itself.
But here is the paradox that just completely blew my mind when looking at how this is diagnosed.
Oh, the positioning issue during exams.
Yes. If you are a patient experiencing this dropping sensation and you go into a clinic, they will likely put you in that standard flat lithotomy position for the exam. But lying flat on your back can completely mask the severity of the prolapse.
It's true. It acts as a massive diagnostic trap for clinicians. Because by lying the patient flat, gravity is no longer pulling the bladder down into the canal.
It's pulling it back into the abdominal cavity,
Yeah.
right?
Exactly. The dorsal lithotomy position can completely hide a really severe cystosol. So if a patient describes pelvic heaviness or a noticeable bulge, but the physical exam shows nothing, a thorough clinician knows they have to change the geometry.
They have to get gravity back involved.
Right. They will have the patient stand up or sit at a 45-degree angle in a specialized birthing chair and perform a Valsalva maneuver.
Which is basically bearing down like you're trying to lift something really heavy.
Precisely. Forcing the intra-abdominal pressure to spike while gravity does its work reveals the true mechanical failure of that support hammock.
Okay, but let me push back on this logically, though. Because if the core problem is that the bladder is dropping down and physically protruding outward into the vaginal canal, shouldn't it be easier to reach in a standard flat position?
Because the bulge is lower down.
Yeah. I mean, the bulge is literally right there at the entrance of our metaphorical cave.
It seems entirely counterintuitive, doesn't it? I mean, the bulge is indeed right there, but a pelvic floor reconstruction is not a cosmetic procedure.
Right. They aren't just snipping away the extra tissue.
No, not at all. The surgeon isn't just trimming away excess tissue from the bulge. If they only did that, the bladder would just fall right back down the very moment the patient stood up.
Oh, right. Because the support structure is still broken.
Exactly. They have to rebuild the entire architectural support system that holds the bladder in place.
Ah, okay. So they actually need to reach the anchor points holding the hammock to the walls.
They need to reach the deepest load-bearing anchors in the entire pelvis. The primary one is often referred to simply as the white line.
The white line.
Yeah, it's a dense band of connective tissue running along the pelvic sidewall. They also need to reach all the way back to the ischial spines, which are these bony protrusions deep inside the pelvis.
Wow, that is deep.
It is. You just cannot properly reattach the detached vaginal tissue to its rightful place if you can't see the apex, like the very top of the vagina.
And in a standard flat lithotomy position, you just can't see it. The patient's bowels and the bladder itself are sitting right on top of the surgeon's sightline, basically blocking access to those deep anchors.
Which means the geometry of the room has to change. If the standard approach fails to reveal the deep anchors, the surgical team has to manipulate the operating table and, by extension, the patient's body to move those internal organs out of the way.
And here's where it gets really interesting. This is the major upgrade. The dorsal lithotomy with pelvic elevation.
Right. The first step is elevating the pelvis itself, which is usually achieved through specific table adjustments or using specialized wedge padding right under the sacrum.
Okay, so pushing the hips up.
Yep. And simultaneously, the patient's hips are flexed significantly greater than 90 degrees. They are pushed into extreme hyperflexion, bringing the knees much, much closer to the chest.
And then comes the Trendelenburg tilt. The entire operating table, with the patient secured to it, is tilted 10 to 15 degrees so that the head is physically pitched lower than the pelvis.
It's quite an extreme angle.
It really is. To picture how this actually works inside the body, think of a deeply packed, upright suitcase. When it's standing up, all your clothes and shoes are just sitting at the bottom, packed tightly together by gravity.
Right, all squished down.
But if you tip that suitcase backward onto the floor, gravity pulls all those loose contents away from the front panel. It instantly reveals the very bottom lining of the suitcase.
I love that visual. That lining perfectly represents the anterior vaginal wall. By initiating that head-down Trendelenburg tilt and elevating the pelvis, gravity literally becomes the surgeon's assistant.
Doing the heavy lifting for them.
Exactly. It gently pulls the small bowel and other intraperitoneal organs up toward the diaphragm, completely away from the surgical field, and simultaneously it allows the anterior bladder wall and the urethra to drop downward into plain view.
It essentially opens up a hidden corridor straight to the deep pelvis.
It creates a crystal clear field of vision. This extreme combination of pelvic elevation and hyperflexion is the only way surgeons can safely perform the incredibly delicate, sharp, and blunt dissection required.
Because they're working so close to other vital organs.
They are operating millimeters away from the bladder wall. They need absolute visual clearance to mobilize that tissue without making blind cuts.
Makes sense.
Once that corridor is open, they can finally visualize the deep ligaments, stitch the vaginal flaps to the lateral pelvic sidewall, and restore that natural hammock we talked about.
But, we have to address the reality of this.
Yeah.
You cannot just take a human being, tilt them upside down, bend their hips in half, strap their legs into metal stirrups, and leave them like that for a 3-hour surgery without severe physiological consequences.
You really cannot. The human vascular and nervous systems are incredibly fragile, and they just do not tolerate prolonged extreme compression.
No, of course not.
The very geometry that saves the pelvic floor can easily destroy the legs if it isn't managed with absolute mechanical precision.
Yeah, we are talking about the physics of risk here. Let's look at what actually happens to the body when things go wrong in this elevated dorsal position. And the first major threat is compartment syndrome.
Right. To understand compartment syndrome, you have to picture the muscles in your lower legs. They aren't just floating freely, they are tightly bundled inside these inelastic sheaths of connective tissue called fascia.
Basically like a tight casing.
Exactly. These bundles are the compartments. So during a long surgery with the legs elevated and compressed against stirrups, the blood flow struggles. If a blood vessel is compressed, fluid can begin to leak into the surrounding muscle tissue, or internal bleeding might even occur.
But because that fascial wrapping doesn't stretch, the fluid has nowhere to go.
The pressure inside the compartment skyrockets. It eventually builds to the point where it crushes the capillaries, completely cutting off oxygen to the muscle cells and nerves inside.
Wow, that sounds horrific.
The muscle tissue essentially begins to suffocate inside its own wrapping. It is immensely painful, highly dangerous, and often requires emergency surgery to literally slice the fascia open and relieve the pressure.
Oh, wow. And then you also have lower extremity asthenia, which is a direct restriction of the blood supply, right?
Yeah.
Imagine a heavy, rigid strap pressing directly into the back of your knee for hours.
Just completely pinching off the flow?
Yeah, the blood flow slows to a mere trickle. The tissue below the knee is slowly starved of oxygen.
And alongside the vascular threats, you have the neurological ones. There are specific nerve pathways, the sciatic nerve running down the back of the leg, the femoral nerve in the front of the thigh, the peroneal nerve near the knee, and the posterior tibial nerve that are acutely vulnerable here.
Because they're being bent at such extreme angles.
Yes. If a patient's leg is improperly aligned, or if it is strapped too tightly into a rigid metal stirrup while the hip is hyperflexed, those nerves get stretched tight like a guitar string against a sharp edge.
And the protective sheath around the nerve gets damaged, which can lead to foot drop, chronic pain, or even permanent loss of sensation. I mean, the patient wakes up with a perfectly repaired pelvic floor, but they can't walk properly.
It's a devastating outcome. But this is where mechanical engineering steps in to solve a biological crisis. To mitigate these extreme risks, the medical field has developed incredibly advanced limb positioning systems.
Which brings us to a fascinating piece of technology detailed in an Australian patent we pulled. It's patent AU2052299719B2. And honestly, when you read the schematics, it looks like a blueprint for high-end robotics.
It really does.
But its sole purpose is to gently cradle a human leg during these extreme surgical angles.
Yeah, the patent outlines a huge departure from the traditional static stirrup. It introduces a dynamic sled assembly that rides along a base bar, which is securely attached to the side of the operating table.
The absolute genius of it lies in a component called a polyaxial ball joint.
Right, the polyaxial ball.
If you think about a rigid stirrup, it only moves in a few clunky directions. You lock it in and the leg is just trapped in a vise. But a polyaxial joint mimics the complexity of a human shoulder.
It has full rotational freedom.
Exactly. It allows the surgical team to make fluid, measured microadjustments in three-dimensional space.
And that fluidity is the ultimate safeguard. During a pelvic floor repair, the surgeon might need extreme internal or external rotation of the leg just for a few minutes to open up a specific visual angle into the deep pelvis.
Right, just a tiny adjustment can make a huge difference in what they can see.
Exactly. The polyaxial ball allows that rotation safely, and crucially, it connects to a specialized padded boot that entirely encases the patient's heel.
So instead of a thin strap digging into the calf and pinching the peroneal nerve, the pressure is dispersed evenly across the entire foot and lower leg.
The sled assembly absorbs and distributes the compressive forces that would otherwise be localized on a single vulnerable nerve pathway.
But there is another deeply practical layer to this mechanical solution that solves an invisible problem in the operating room, which is sterility.
Yeah, maintaining the sterile field is the absolute bedrock of surgical safety. Any breach can lead to a catastrophic infection.
Right, and the dynamic sled assembly we just described has to physically attach to the metal rails of the operating table. But those rails are covered by sterile surgical drapes.
Which are usually just thin plastic or fabric.
Yeah. Normally, if you take a heavy industrial metal clamp and crank it down onto a rail covered in thin plastic, the torque and friction will shred the drape instantly.
And the moment the drape tears, the non-sterile metal of the bed rail is exposed to the sterile surgical field, and the entire setup is compromised.
But the engineers solve this by integrating advanced material science directly into the clamp assembly. The system uses a specialized buffer pad between the clamp jaws and the draped rail. The patent specifically highlights the use of para-aramid synthetic fibers,
Right, and most people know para-aramid fibers by their commercial name, Kevlar.
which is so cool. They are essentially using bulletproof vest material in the surgical clamps.
It's brilliant.
The Kevlar pad is incredibly thin but possesses massive tensile strength. It acts as an indestructible friction buffer.
So they can really crank it down.
Exactly. The surgical team can torque the heavy metal clamp down onto the rail with immense, bone-crushing pressure to hold the heavy sled assembly secure. And the Kevlar protects the delicate, sterile drape from tearing.
If we connect this to the bigger picture, it perfectly illustrates how modern surgery is an exercise in risk mitigation across multiple disciplines.
It really is a balancing act.
Right. You have a pelvic reconstruction that demands extreme anatomical angles. You have nerves and blood vessels that demand gentle, evenly distributed pressure. And you have an environment that demands absolute sterility. Devices like this patented sled assembly somehow synchronize all those conflicting needs.
So the surgical team isn't just locking the patient in and hoping the nerves survive. They can fine-tune the human body's geometry in real time, providing the exact degree of hip flexion and pelvic tilt required to reach that deep anterior wall while actively protecting the vascular system.
It transforms the procedure from a really dangerous physiological trade-off into a highly controlled dynamic process.
It really is a profound marriage of human anatomy, the manipulation of gravity, and specialized mechanical engineering. We've traced the journey from the ancient roots of the standard lithotomy to the deep anatomical challenge of a falling bladder.
We've covered a lot of ground.
We really have. We've seen how tipping the body like a suitcase clears the path for the surgeon, and how Kevlar and polyaxial joints keep the patient's nervous system completely intact.
It is a massive triumph of physical medicine. But, looking at all this literature, there is a fascinating non-physical complication to this geometry that we definitely have to consider.
Wait, really, what's the hidden cost here?
The psychological one. While many major pelvic floor reconstructions are done under general anesthesia, a lot of procedures utilizing the lithotomy position are actually done while the patient is awake or just under conscious sedation.
Oh, wow. I hadn't thought of that.
Yeah. And the medical literature points out that patients often experience a profound loss of control and an intense sense of psychological vulnerability when they are placed in this position.
Which is entirely understandable. I mean, you are physically restrained, your legs are elevated and spread in an incredibly intimate posture, and because of the angle, you cannot see anything the medical team is actually doing.
You are entirely disconnected from what is happening to your own body. So as we look to the future, it raises a really compelling question about the trajectory of surgical innovation.
Right, because tech is always advancing.
Exactly. We are seeing rapid advancements in robotic surgery, flexible endoscopes, and minimally invasive techniques that can navigate incredibly tight angles inside the body.
So, if a robotic arm can articulate its way around the bladder without needing a straight line of sight,
Will we eventually abandon these extreme, historically rooted physical postures entirely? Will the future of surgery prioritize the psychological comfort and bodily autonomy of the patient just as highly as it currently prioritizes physical access for the surgeon?
That is a brilliant thought to leave on. We started this deep dive thinking about surgery as a mechanic working on an engine. But engines don't feel vulnerable. Engines don't have nervous systems that get starved of oxygen. As the tools we use get more precise, maybe the way we handle the human blueprint will become a lot less mechanical and a whole lot more human. Thank you so much for joining us for this deep dive. Keep questioning the hidden mechanics of the world around you, and we'll see you next time.